Welcome back to another deep dive. I have to be honest with you, when I first pulled up the file for today's topic, I almost scrolled right past it.
I can see why.
The label was just salvage treatment for cat maxilla. It sounds incredibly dry, almost like administrative paperwork.
It does have that ring to it, but cat is just medical shorthand for cancer, and maxilla is the upper jaw. So we're not talking about coding, we're talking about one of the most complex parts of the human body.
Exactly, and that's the hook, right? Once I opened the file and started reading through these, these surgical protocols and decision trees, I realized we're looking at something incredibly high stakes.
Oh, absolutely.
We're talking about operating on the human face. And not just fixing a nose. We're talking about dismantling and rebuilding the very structure of someone's identity.
That's a great way to put it. The maxilla isn't just a bone, it's the architectural center of the face. It holds your eye up, it separates your mouth from your nasal cavity.
It forms your cheekbones.
Exactly. So when you talk about salvage treatment here, you're balancing this desperate need to get the cancer out with the reality that you can't just hack away at someone's face.
And that's the tension I really want to unpack today. We've got a stack of sources here. Surgical guides, checklists, even some pharmacological notes that look like they're from, I don't know, the 19th century.
Some of them practically are.
And our mission is to understand how surgeons navigate that minefield.
It really is a minefield. And usually, by the time we're even talking about salvage, the patient has already been through a lot. The protocol mentioned right at the top usually starts with preoperative radiotherapy.
They blast the area with radiation first.
Yeah.
Shrink the tumor, right?
Yeah.
Make it smaller before they try to cut it out.
Exactly. But here's where it gets tricky. That radiation, it changes the texture of the battlefield. Radiated tissue is stiff. It doesn't heal well.
Right.
It doesn't stretch like normal skin. So when the surgeon walks in, they're already working with compromised materials. They have to anticipate failure before they even make the first cut.
Which brings us to the first massive hurdle in these documents. Getting in.
The approach.
Right. I mean, if I need surgery on my appendix, the scar is covered by my shirt. But here, you're operating on the face. You can't exactly hide that.
No.
The sources list a few ways to get to the maxilla. There's wide excision, endoscopic removal for smaller things. And then there's this term that, frankly, made me cringe.
I think I know which one you mean.
Midfacial degloving.
Yeah. It's a visceral term, isn't it? It sounds like something from a horror movie.
It really does. Please tell me it's not as bad as it sounds.
Well, it's actually a very elegant, if intense, procedure. You make incisions inside the mouth, under the lip, and inside the nose.
Okay.
And then you literally peel back the soft tissue of the face. The skin, muscle, the nose upward, almost like taking off a glove or a mask.
Wow.
It exposes the entire facial skeleton without making a single cut on the external skin of the face.
So you're essentially lifting the face off the skull to work underneath it.
Precisely. It gives you incredible access without a visible scar.
But the sources seem to suggest that for the big, aggressive tumors, the ones needing a full maxillectomy, you can't always do that. They spend a lot of time on a specific incision called the Weber-Ferguson approach.
Ah, the Weber-Ferguson. It's the gold standard. It's the classic for a reason. And if you look at the diagrams in the source material, it's a masterclass in using anatomy to cheat the eye.
Hiding the damage in plain sight.
That's it, exactly.
Okay, let's break that down because I was trying to trace this on my own face. It starts near the eye, goes down the side of the nose, and then it cuts the lip. But it doesn't just go straight down the middle, does it?
No, and that's a rookie mistake. If you cut straight down the midline of the upper lip, as it heals, the scar contracts, it tightens, and it pulls the lip up into this permanent snarl. It looks very unnatural.
So where do they go instead?
They follow the crest of the philtrum. You know that little vertical groove above your upper lip?
The divot.
The divot, right, the philtrum. There are ridges on either side of that where the light hits. The incision runs right along that ridge. By placing it there, the scar just hides in the natural shadow and topography of the face.
That's so smart. But then there's this mention of a step. It says the incision steps on the lip.
This is all about the geometry of beauty, really. When the incision hits the red part of the lip, the vermilion border, it doesn't go straight across. It does a little zigzag, a step.
Why complicate it with a zigzag?
Because the human eye is incredibly good at noticing a broken straight line. If you have a straight scar there, even a millimeter of misalignment makes the lip look disjointed. By creating a step, it lets the surgeon lock the two sides back together like a puzzle piece.
So it breaks up the line?
It breaks up the line so your eye just glides right over it. It's optical camouflage.
Okay, there's another detail here that seems totally counterintuitive. It talks about the transverse limb, the cut going across the cheek, and says it has to be placed close to the lid margin. So right up under the eyelashes.
Yes. And this is one of those insider secrets of the trade. You might think, I want to stay away from the eye. I should cut lower on the cheek to be safe.
That would absolutely be my first instinct. Give the eye some space.
And if you did that, you would likely ruin the patient's face.
Really? How?
It's all about fluid dynamics. The lymphatic drainage, the system that drains fluid from your face, runs a certain way. If you cut low on the cheek, you sever those channels. So gravity takes over, fluid pools in the lower eyelid, and it creates this massive, permanent, swollen bag under the eye. We call it chronic lymphedema.
So by cutting higher, right under the lashes.
You bypass those channels, you preserve the drainage highway, the patient doesn't wake up with a permanently swollen eye. It's amazing how much physics is involved here.
It really is. Okay, one last incision detail before we get to the bone. The nasal curve. The source mentions curving the incision forward over the nasal bone.
Yes, this goes back to that preoperative radiation we talked about.
Because the skin is weak.
Exactly. Remember, radiated skin is fragile. If you stitch that weak skin together over a hollow space, it might just fall apart. The medical term is dehiscence.
That's a terrible image.
It's a terrible outcome. So by curving the incision so it lies on top of the nasal bone, you're ensuring the scar is resting on something solid. You're borrowing the strength of the bone to hold the delicate skin together.
So we've tricked the eye, we've preserved the drainage, supported the weak skin, we're in. Now we have to remove the cancer. And the terminology here shifts from geometry to, well, it sounds like demolition.
It is controlled demolition. You're taking apart a building while trying to keep the roof from collapsing.
The sources list different levels of maxillectomy, partial, subtotal, toe. It feels like a ladder of aggression.
It is. You start with the least invasive and work your way up.
So a partial maxillectomy, what are we losing here?
This is for smaller, contained tumors. If it's a medial maxillectomy, you're taking out the sidewall of the nose and the ethmoid sinuses, those air pockets between your eyes.
And inferior.
That's the floor, the hard palate, the roof of your mouth, and the gum line.
Okay, so you lose some teeth, part of the palate. Significant, but manageable. But then we get to this distinction I found really fascinating. The difference between subtotal and total.
This is arguably the most critical distinction in the entire document.
The text says a subtotal maxillectomy removes at least two walls, but, and this is bolded in my notes, it preserves the floor of the orbit.
Let's visualize that.
Yeah.
The orbit is the eye socket. The floor of the orbit is the little shelf your eyeball sits on. In a subtotal procedure, you are fighting to keep that shelf intact.
Because if you don't.
If you take that shelf away, the eyeball has nothing to sit on. Gravity wins again, the eye sinks, it drops down into the cavity you've just created.
Which I assume causes massive vision problems.
Massive. It causes double vision because the eyes aren't aligned anymore, and cosmecally the eyelids sunk in and deep in the face. Preserving that floor is everything.
But sometimes, you can't save it.
I know, sometimes the tumor is just too big, and that's the total maxillectomy.
The source lists the osteotomies, the bone cuts for this, and reading the list really drives home the violence of it.
You're effectively disconnecting the midface from the skull. You have to free the entire block.
Let's walk through them. First, the zygoma,
The cheekbone, you saw through it right underneath the eye socket.
then the frontal process of the maxilla,
That's the bar of bone that runs up the side of your nose toward your forehead. Snip that.
then the piriform fossa, the nasal opening, and the heart palate,
Right down the middle of the roof of the mouth, splitting it in two.
and finally the pterygoid plates.
Those are deep in the back, behind your wisdom teeth. They connect the face to the base of the skull. Once you cut those, the entire upper jaw is free. You can just lift it out.
And it leaves this massive void.
A void that connects the mouth, the nose, and the eye socket into one big cavern.
And the source says it can get even worse. Extended maxillectomy. If it goes up, it's a craniofacial resection.
Taking part of the skull base,
If it goes out, enterofacial.
taking the skin of the cheek. But there's one step further, the one that every surgeon dreads.
Section 3 in our outline, the radical shift.
Radical maxillectomy.
This is where the list of what's removed includes orbital contents.
Taking the eye. The medical term is orbital exenteration.
The source is very specific here. It's the maxilla, nasal bone, sinuses, and the eye. But it doesn't seem like a decision that's taken lightly. There's a checklist of indications.
Oh, it's a strict protocol. You don't take an eye just because the tumor is near it. Sight is too valuable. You only take it if the tumor has breached specific no-go zones.
The list includes the orbital apex. What's that?
That's the funnel at the very back of the eye socket where the optic nerve comes in. If a cancer's there, you can't cut it out without cutting the nerve anyway. The site is already doomed.
Extraocular muscle.
The muscles that steer the eye. If you have to cut those to get the cancer, the eye becomes a dead weight. It won't move. It's a liability, not an asset.
And this one, retrobulbar fat.
The cushion of fat behind the eyeball. The problem with fat is that it has no containment. It's not like muscle or bone. If cancer gets into that fat, it's like dropping ink into water. It spreads everywhere. You have to clear the whole socket.
Devastating. But I noticed the document also has a hard stop, a point of unresectability. Times when the surgeon has to say, I can't do it.
There are boundaries we still can't cross.
The cavernous sinus.
That's a venous highway deep in the skull. It holds the carotid artery, the main blood supply to the brain, and critical nerves. You cannot operate inside it. It's instant death or a massive stroke.
Bilateral optic nerve involvement.
Meaning the tumor has wrapped around the vision nerves for both eyes, leaving a patient completely blind with a massive facial defect that is often considered a bridge too far.
It's sobering to see those limits written down. It reminds you that biology still wins sometimes.
It keeps you grounded. You have to know when to stop.
So we talked about the cutting, the bone. Now I want to pivot to something that totally surprised me. Section 4, the pharmacological toolkit.
The cocktail menu.
I'm reading the ingredients for something called Moffitt solution used during the surgery. It lists 2 milliliters of 10% cocaine.
I knew you'd flag that one.
Cocaine in a modern operating room, along with adrenaline and sodium bicarbonate.
It sounds like something out of the 1800s, doesn't it? But yes, cocaine is still used in this specific context.
Why? I mean, I thought we moved past that decades ago.
Because it does two things better than almost anything else. First, it's a fantastic local anesthetic, but more importantly, it is a powerful vasoconstrictor. It clamps down on blood vessels.
And why is that so critical here?
Think about the last time you had a nosebleed.
It goes everywhere. A total mess.
Bleeds like crazy, right? The inside of the nose and the sinuses are incredibly vascular. If you just cut in there, it's a bloodbath. You can't see what you're doing. The cocaine and adrenaline shrink those vessels so the field stays dry. It lets the surgeon actually see,
The source does mention a modified Moffitt's that uses xylocaine instead.
which is common now, mostly to avoid the regulatory headache of stocking medical-grade cocaine. But the principle is the same. Stop the bleeding before it starts.
And then there's this other one, Whitehead's varnish.
For the packing.
The ingredients list includes iodoform, benzoin, storax, tolu balsam, and solvent ether. It sounds like something you'd use to polish furniture.
It smells a bit like it too. It's very aromatic, very pungent.
What is it for?
Okay, so imagine you've just done this total maxillectomy. You have this giant raw cavity inside the face. You can't stick a Band-Aid on it. You need to pack it with gauze. But plain gauze would stick to everything.
And when you pull it out,
It would rip all the new tissue off and you'd be back to square one, bleeding everywhere. So you soak the gauze in this varnish. The benzoin and balsams make it a waterproof seal. The iodoform is a strong antiseptic. It turns the gauze into a medicated plug that can stay in for weeks while things heal underneath.
it's just such a contrast. You have these high-tech scans and lasers, and then you're using balsam and benzoin like a Victorian apothecary.
Sometimes the old ways work best.
So the surgery is done, the cavity is packed. How does this person live? Section 5 talks about aftercare.
Immediate rehabilitation.
Because if you remove the roof of the mouth, you can't eat right. Food would go straight up into your nose.
You can't eat and you can't talk. To make speech sounds, your tongue pushes against the palate. If the roof is gone, your voice is just air escaping through your nose.
The source mentions a gutta percha palatal prosthesis.
Gutta percha is a thermoplastic material. Gets soft when hot, hard when cool. Right there in the OR, while the patient is still asleep, they mold a plug, we call it an obturator, that fits perfectly into that new hole.
So the patient wakes up with it already in place.
Yes, it immediately restores the partition between the mouth and nose. It means they can swallow water and say hello to their family right after waking up. It's a huge psychological win.
And then the final phase, we're still not done. Adjuvant therapy.
The safety net.
The protocol splits here. The source says for slow-growing tumors like adenoid cystic carcinoma, they go to post-op radiotherapy.
Right. Slow growers tend to respond better to radiation. You're trying to sterilize the field locally.
But for the fast ones, olfactory neuroblastoma, lymphoma, they bring in the heavy artillery, chemotherapy.
Because those cancers are aggressive, they're likely to have thrown microscopic cells into the bloodstream. You need a systemic treatment chemo to chase them down.
There was one specific treatment here that really caught my eye. Topical 5-fluorosil.
5-FU.
Topical chemo, like a cream.
Essentially, the source notes it's for adenocarcinoma of the ethmoid sinus. They literally paint the chemotherapy drug right onto the lining of the cavity.
That is incredible precision, targeting the exact spot where the tumor lived.
It's about trying to catch that one last cell hiding in the nooks and crannies.
It's such a grueling journey. We've gone from the first cut along that philtrum ridge, carefully stepping over the lip, to sawing through the cheekbone, packing the wound with iodoform varnish, and finally painting it with chemo.
It is. But you have to remember the alternative. These tumors, if you leave them, are horrific. They take the eye, they invade the brain, they suffocate you. This surgery, as brutal as it sounds, is a rescue mission.
And that's the takeaway for me. We look at these files and see technical details, but what we're really seeing is a map of how far we can push into the human body to save a life without losing the person inside.
And doing it with enough finesse, using those fluid dynamics, those geometric cuts, that they can still face the world afterwards. It's not just about survival, it's about restoration.
An incredible balance of anatomy, pharmacology, and courage. Thanks for walking us through this file.
My pleasure.
And for everyone listening, next time you look in the mirror, take a second to appreciate the orbital floor holding your eye up. You'd definitely miss it if it were gone. We'll see you on the next deep dive.